Glucose 6-phosphate dehydrogenase or G6PD deficiency is a genetic disorder and is the most common human enzyme deficiency. Individuals with severe G6PD deficiency are vulnerable to serious health threats such as hemolysis of red blood cells or hemolytic anemia. G6PD catalyzes a reaction in the pentose phosphate pathway, or known as a metabolic pathway that supplies reducing energy to cells such as erythrocytes by maintaining the level of the reduced form of the coenzyme nicotinamide adenine nucleotide phosphate, or known as NADPH. G6PD is essential for protecting erythrocytes in the presence of oxidizing agents. The FST or fluorescent spot test for G6PD deficiency involves of this reaction. To perform the test, a small amount of blood is incubated with glucose 6-phosphate and NADP in the substrate reagent and then is spotted on filter paper. Once dry, the spots are viewed under a long-wave ultraviolet or UV light. The product of the reaction NADPH is fluorescence. NADPH fluorescence is directly proportional to G6PD activity, and lack of fluorescence signals G6PD deficiency.
For specimen, currently all protocols recommend the use of venous blood. However, there is not sufficient data to recommend the use of capillary blood in fluorescent spot assays. It is acceptable to use EDTA or acid citrate dextrose (ACD) anticoagulants.
Here are the reagents being used to test the G6PD fluorescence screening test, which is Trisma buffer, lilophilic G6PD reagent, G6PDH control lilophilic powder.
Quality control or QC is the most important impact on the laboratory testing. It ensures both precision and accuracy of patient sample result. When quality control works effectively, it is able to find and correct the flaws in the analytical processes of lab before potentially incorrect patient results are released. For G6PD, there are few components of usage that need to be aware. For example, test kit controls, internal control lines for POCTs, external quality control specimen, proficiency panels, limits of acceptability. For test kit controls, manufacturers supply positive and negative test kit controls. It will be run as indicated in the IFU for all test formats at the common segment of each testing session. Where positive and negative test kit controls are not supplied by the manufacturer, as will be the case for many rapid diagnostic tests, the laboratory will provide an in-house quality control specimen. Next, for internal control lines for POCTs, generally, most POCTs contain a control band, line or spot to determine that the test device is operating correctly. Most control bands or lines spots will become visible with the additional of reagent, for example buffer. However, some POC tests will contain a control band or line or spot that becomes visible with addition of specimen. It is imperative that the exact nature of the control band or line or spot is ascertained and recorded in the report. An experiment using distilled water instead of specimen is performed to verify this point. Next, external quality control specimen. The WHO PQ evaluating laboratory supplies two external quality control specimens, one G6PD normal and one G6PD deficient. These are tested at the beginning of each test session. The QC specimens are provided by the PQ evaluating laboratory or acquired commercially. Last but not least, proficiency panels. A proficiency panels must be run successfully for each assay by each operator before the evaluation commences. This may be the same panel as that used at the time of assay demonstration by the manufacturer or for training purposes. Lastly, limits of acceptability. All results on test kit controls and QC specimen are entered on the data collection sheets. Should the test kit controls or the QC specimen not give the expected result, testing is suspended until the cause has been identified and satisfactory solution identified. Such problem must be communicated immediately to WHO or PQT and recorded on the data sheets. The PI is responsible for carefully checking all data entry forms for legibility, accuracy, and completeness.
A case report of G6PD which been studied by J in 2017 has been brought to the point of practical application in clinical applications of this G6PD. According to this study, G6PD is an enzyme used in glucose metabolism. A deficiency causes precipitation of oxidized which causing the formation of hence bodies, hemoglobin, and may result in hemolysis of variable severity. It is sex-linked recessive trait carried on the X chromosome. The full effect of this genetic defect is not manifested if the normal gene is present on a second X chromosome to oppose the genetic defect. In males, there is no second X gene and the genetic defect is unopposed. Affected males inherited this abnormal gene from their mothers, who are usually asymptomatic. However, these males, the disease is more severe. The severity of symptoms associated with G6PD varies greatly from case to case, depending upon the form of the disorder that is present, and some people have no symptoms at all. When symptoms are present, they may include fatigue, pale color, shortness of breath, rapid heartbeat, jaundice or yellow skin color. In the United States, G6PD is found mainly in African Americans. About 10% to 15% of the population is affected by the disease. Also, those of Mediterranean descent, Italians, Greeks, Paradet Jews are at risk for the genetic defect.
The G6PD advanced lab test is quantitative spectrophotometer assay. What is quantitative spectrophotometer assay is to be measured by spectrophotometer which used in the radiation in absorption of the sample at 340 nm over the time to determine the production of NADPH. The gold standard of the accessing this G6PD enzyme activity in our red blood cell is the spectrophotometric test, which will be provided as a weight average of the activity G6PD deficiency and also the G6PD normal cells in any sample. As a result, it will utilize as a benchmark against which the future point of the care test are measured in the both quantitative and qualitative. We have to note the concentration of the hemoglobin in the blood sample that might influence in the finding in a anemic or the iron deficiency in the G6PD reading. As per conclusion, G6PD deficiency is a hereditary condition that affects the red blood cell where transport the oxygen from the lung to all our body. A deficiency in enzyme called G6PD that caused the red blood cell breakdown earlier in affiliated people, where hemolysis is a term of breakdown of the red blood cell. G6PD deficiency has no treatment and it is a lifelong illness. But most people with G6PD, they may live a normal life that provided they can avoid the triggerness. It frequently easy to eliminate the trigger to treat the G6PD deficiency symptoms. This usually entails treating the infection and discontinue with the usage of medication.